Our next speaker this morning is Dr. Raja Iskandar Azwa, who is well known to many of us here in the audience as he's one of the leading men in the fight against HIV in Malaysia, and he's generously shared his knowledge and expertise with us at previous symposia. He currently serves as an associate professor at the Faculty of Medicine at the University of Malaya in Kuala Lumpur, where he's the clinical lead for HIV. He received his medical training at the University of Dundee in the UK, and he completed his specialty training in genitourinary and HIV medicine at Chelsea and Westminster Hospital in London before returning to Malaysia in 2009. We are honored that he's here with us again. Thank you very much, Dr. Iskandar.
Thank you very much, Eugene, for that very kind introduction. And thank you once again for Thai Red Cross, AIDS Research Center, and HIV-NAT for inviting me to speak today at the symposium. So today I'm going to be talking about the art of initiating antiretroviral therapy. So the outline of my talk is essentially when to start antiretroviral therapy, rapid initiation of antiretroviral therapy with a focus on same-day antiretroviral therapy and guidelines guiding us to this. And I'm going to end up with what to start antiretroviral therapy with a focus largely on middle and low-income countries and recent updates in international guidelines. And finally, I'm going to conclude with recent ART-naive studies in resource-limited settings. So just to start off, when to start antiretroviral therapy? Now, really, the debate about starting antiretroviral therapy should have ended in 2015 with publication of the research findings of the START study and the Temprano study, which showed basically a significant reduction in serious events and death in both studies. Also coupled to this was the HPTN 052 study, which showed a significant reduction in linked transmission to partners, supporting the evidence of early antiretroviral therapy. So really at this point I could end that topic of when to start ART. But the reality of it is that certain collaborators in this room have been trying to, and globally have been trying to push and raise that bar further. So why push for earlier antiretroviral therapy? Well, guidelines are shifting with this respect. WHO, IS, USA, and DHHS are now looking to start therapy more rapidly. There are high attrition and dropout rates between the first positive HIV test and ART initiation. And this is largely due to long waiting times for baseline lab results and an insistence on ID physicians to wait for the results prior to starting antiretroviral therapy. In certain parts of the world, in particular Africa, multiple visits are required before initiation of antiretroviral therapy on the assumption that the clients need to be adequately prepared before starting antiretroviral therapy. But delays in treatment have been associated with negative outcomes, such as increased mortality and reduction in CD4 count recovery. We know that earlier antiretroviral therapy is associated with a reduction in HIV transmission, and following on from the earlier talk, earlier antiretroviral therapy limits the size of the viral reservoir in acute infections, and therefore allowing for potential earlier cure options. So in this era of rapid antiretroviral therapy versus same-day antiretroviral therapy, we often get confused about the terminology. And just for the purposes of the initial part of this talk, rapid antiretroviral therapy is defined by WHO as starting antiretroviral therapy within 7 days of the HIV diagnosis. Same-day antiretroviral therapy, on the other hand, is literally starting antiretroviral therapy on the same day of the HIV diagnosis, or what is more feasible if you're not a testing center, is to start treatment on the first day of the HIV clinic visit. So, and the complexities around the logistics of trying to maneuver patients and change and adapt to same-day antiretroviral therapy differ between the two. The notion of same-day antiretroviral therapy, therefore, that the notion is that people should not be coerced. So there's no element of force. And that can sometimes be confused if you elevate this to programmatic level. But patients should be supported in making an informed choice regarding when to start antiretroviral therapy. And what essentially is also different is that the HIV counseling and the antiretroviral therapy education start on the same day of antiretroviral therapy initiation and continue after the patient is initiated on treatment. The reason why we need to think about this collectively is because treatment cascades across our region is not perfect, in particular the 1990 cascade. And this is, if you look particularly at Malaysia, which the targets for HIV testing have been depicted as quite good, but it significantly falls to 39% at the subsequent 90 targets. So this represents a significant drop. So there is a problem here. Patients are being referred, but they're not initiating antiretroviral therapy. And there's a multitude of reasons for this, but a lot of it is structural, and some of it would be due to outdated notions of infectious disease physicians. This is a systematic review looking at same-day antiretroviral therapy initiation done in 2018. Unlike a lot of HIV research, which starts out in resource unlimited settings, this was done in resource-limited settings, and they were randomized controlled trials, looking specifically at same-day antiretroviral therapy. There was 4 of them, and essentially what it showed is that compared to the standard of care, same-day antiretroviral therapy was associated with a greater likelihood of ART initiation within the first 3 months, a greater likelihood of retention in care at 12 months, and a greater likelihood of viral suppression at 12 months. So the evidence for same-day antiretroviral therapy started in resource-limited settings in countries such as Haiti, South Africa, and Uganda, and then subsequently and more recently, there are data emerging from the US, largely from clinic-based cohort studies, resulting in subsequent change of recent guidelines. This year, there was a Cochrane review of a rapid initiation of antiretroviral therapy of people living with HIV. This, once again, is different from same-day antiretroviral therapy. Here, they defined rapid antiretroviral therapy as offering antiretroviral therapy within 7 days of HIV diagnosis. 7 studies were looked at with a total participants size of 18,000 participants. It was restricted to low and middle income countries, and compared to standard of care, rapid antiretroviral therapy achieved similar outcomes as in the previous systematic review, i.e. greater viral suppression at 12 months, better ART uptake at 12 months, and a trend towards improvement in retention in care. WHO has made fairly strong recommendations about rapid antiretroviral therapy initiation since 2017, that all persons living with HIV following a confirmed HIV diagnosis should be offered rapid antiretroviral therapy. It goes on to say that they should be offered same-day antiretroviral therapy to people who are ready to start. And these are strong recommendations, backed by high-quality evidence. More recently, the DHHS guidelines in 2019, so about a month ago, took a fairly tremendous shift in the sense that they were very much on the fence initially, owing to lack of data within the US, and saying that same-day antiretroviral therapy is largely an investigational approach which needs to be explored further and is labor-intensive, to now recommending initiating antiretroviral therapy immediately or as soon as possible after HIV diagnosis. So this is a new recommendation as of the recent update. This follows on from the IS-USA guidelines from July 2018, which state that, or which recommend that ART should be initiated as soon as possible after diagnosis, including same day as the diagnosis, unless the patient is not ready to commit to start antiretroviral therapy. What needs to be emphasized also in programs or in clinics which are attempting to look at same-day antiretroviral therapy is that, and different models have been looked at, in settings whereby you don't have point-of-care tests, you really shouldn't. You can do the blood test, and they should be done before initiation of antiretroviral therapy, but you should not need to have to wait for the results before starting. A lot of the data from the Asia Pacific is from the Thai Red Cross, And so I'm going to present some of their data here. Since July 2017, Thai Red Cross acted as an AIDS, as a ARV initiation hub for newly diagnosed or re-engaged patients, which were referred from the NGOs. And the idea was that they would initiate same-day antiretroviral therapy, initiate the linkage to care, to subsequent tertiary hospitals, have a brief period of follow-up. So after the patient is started on initial antiretroviral therapy, they're seen 2 weeks later, and then subsequently referred out to the referring hospitals. And this was accompanied by a navigator throughout. In order to understand maybe the complexity or otherwise of same-day antiretroviral therapy, this is a typical algorithm that is used in the Thai Red Cross. After a person receives a reactive HIV antibody test, they go through an ART counseling and readiness assessment to see if the patient is ready to start antiretroviral therapy. So the assumption is that they are unless the assessment says otherwise. Everybody goes through an opportunistic infection symptom screening, basically to rule out cryptococcal meningitis or TB. Bloods are then drawn for safety labs, CD4 count, and a reflex cryptococcal antigen if the CD4 count is less than 100. In Thailand, from what I understand, a chest X-ray is done in all patients prior to initiation of antiretroviral therapy, so this is part of the algorithm. And further tests are undertaken if the patient has a positive symptom screen for TB or an abnormal chest X-ray. After that, the patient is seen by a doctor after confirmation of HIV tests, and the chest X-ray is available, and the patient then undergoes a further history and clinical examination, once again to rule out opportunistic infections. In some of the earlier trials looking at in resource-limited settings, particularly in the African setting, a lot of point-of-care diagnostics were used in order to allow the feasibility of the implementation of rapid antiretroviral therapy. But in some situations, this can act as a hindrance to initiation of antiretroviral therapy. The regimen used here was TDF-FTC and efavirenz in keeping with the national guidelines, national Thai guidelines in 2017, and bloods were taken as shown, and once again reiterating that you need not wait for a result before prior to initiation of antiretroviral therapy. The only, I think, result that needs to be the result that needs to be got is a chest X-ray. And no baseline HIV resistance results are done. So when offered, and this is data up to end of 2018, 90% of people accept same-day antiretroviral therapy. So the acceptability, if offered, is very, very high. And this, within this setting, seemed to be higher both in MSM and transgenders compared to heterosexuals. Looking at a patient population of about over 2,000 patients who enrolled into the same-day antiretroviral therapy initiation, 74% were able to be initiated on ART on the same day. So this is quite a remarkable feat. A further 10% were able to be initiated 2 days later, and another 10% within that week. So really, if you look at it, 94% of patients were able to be initiated within the first week. Baseline lab results were abnormal in about 8.7% of patients who had abnormal renal function. But in reality, as long as you have a clear follow-up plan in order to inform the patient, this does not really pose a problem and should not be a hindrance with respect to implementing same-day antiretroviral therapy. What is equally impressive here is month 6 retention, and even more so month 12 retention of 89.7% at month 12, and with a viral load suppression of an equivalent amount. So really, patients who were enrolled into the same-day ART program compared to the standard of care were 3.9 times more likely to start antiretroviral therapy. Similarly, patients who were enrolled in the same-day antiretroviral therapy program were 2.2 times more likely to be viral suppressed, so excellent outcomes. This has subsequently been scaled up within the country to include 9 hospitals in 5 high HIV burden provinces and using different models of same-day antiretroviral therapy. I think some of the barriers within these hospitals were that they required a baseline CD4 count result before initiation of antiretroviral therapy, and some hospitals required safety laboratory results. But this just reinforces what I stated earlier, and if you look on the left-hand side, not using any baseline laboratory results as denoted by the red graph results in a faster initiation of ART with no increase in adverse events or deaths. There are guidelines as well from other parts of the country and resource-limited settings such as South Africa, once again reinforcing the importance of opportunistic infection screening, mainly for TB and cryptococcal meningitis before initiation of antiretroviral therapy. And as long as you do this, really there's a low risk of missing infections if you have a proper screen. Initiation of antiretroviral therapy in the setting of acute opportunistic infections hasn't changed for more than a decade. This study was done more than 10 years ago, and it's tried and tested and remains relevant till today. This was one of the first randomized control trials to look at the optimal timing of antiretroviral therapy initiation in the setting of acute opportunistic infections. And essentially what it showed was that there was a 50% reduction in mortality and AIDS progression across a range of opportunistic infections if you started antiretroviral therapy within 14 days, compared to waiting till after you completed treatment of the OI. And these recommendations, once again, of starting antiretroviral therapy in the setting of opportunistic infections also haven't changed, apart from really where you have to be really concerned is cryptococcal meningitis and TB meningitis, whereby you would want to delay initiation of antiretroviral therapy to 4 to 8 weeks. And not forgetting the community perspectives of antiretroviral therapy initiation. We are here basically because we want to serve the community that we treat. And these are perspectives from the community regarding same-day antiretroviral therapy. This is courtesy of Simon Collins from the British HIV Association conference in April of 2019. Antiretroviral therapy can normalize HIV in periods of high stress. Many patients therefore perceive treating earlier initiation of antiretroviral therapy with a sense of hope and optimism. The message that you really impart patients with earlier initiation of antiretroviral therapy is that there's a sense of urgency to their treatment. If you treat earlier, you reduce the viral load quicker and you reduce transmission to partners. So another advantage. In Dean Street in London, the main reason for offering rapid antiretroviral therapy was because a well-informed group of patients were literally demanding for it. And really, if you think about it, there's very few exceptions to the uptake of rapid antiretroviral therapy. And rapid antiretroviral therapy, in particular same-day antiretroviral therapy, allows you to address structural barriers to care and putting patients at the center of care. So really, some of the lessons learned from same-day antiretroviral models, and these are keys for implementation success. I think globally, certainly in the world of HIV research, we always try and embrace innovation. But there are some of us who find it very difficult to confirm with certain research findings and really want to keep to the same status quo because they feel uneasy when in bringing about changes. As mentioned, same-day antiretroviral therapy addresses structural and other barriers to care. Yes, it is important that you have medical provider buy-in at multiple levels because it needs that level of buy-in in order for it to go ahead, and you require some form of clinical restructuring and flexible scheduling with an increased time spent in clinic with initial visits. So I'm going to change gears a bit away from same-day antiretroviral therapy initiation and talk about what to start. Now, some of the factors to consider when selecting an initial antiretroviral regimen depend on baseline characteristics of patients, such as their pre-treatment HIV viral load, pre-treatment CD4 count, timing of ART initiation after diagnoses. Certain specific conditions such as comorbidities, renal disease, cardiovascular disease will determine also the type of antiretroviral therapy to be initiated, along with co-infections such as that with hepatitis B and hepatitis C. Barriers to resistance play an important part. We would prefer a drug with a higher genetic barrier to resistance, such as Dolutegravir or Dolutegravir right from the start. And potential drug interactions, convenience, costs, all influence the selection of what type of regimen we choose. This year, we have the update of 3 international HIV guidelines. They were recently updated since July 2019. So we have the DHHS guidelines, which were updated in December 2019. So in terms of the initial regimens which were recommended in the, for first-line antiretroviral therapy, and this comes under the recommended for most persons with HIV, we can see that it's largely a integrase inhibitor based regimen throughout. The preference is for integrase inhibitors with a higher genetic barrier to resistance, but Dolutegravir is also included in that list, so which is associated with a lower genetic barrier to resistance. The NRTI backbones don't make a huge difference. It depends on what you have, and it depends on renal function, hepatitis B surface antigen status, and so forth. But what is also interesting that within the DHHS guidelines, following findings from the recent Gemini 1 and 2 96-week data, dual therapy has now managed to creep into the guidelines. So using 3TC and Dolutegravir, but this come with caveats, of course, that your viral load has to be more than 500,000. You cannot be hepatitis B co-infected, and very much in a resource unlimited setting that you need to know the results of the HIV genotype resistant testing before considering this. EACTS guidelines were updated in November 2009, and the recommended regimens are very long, but what I've listed is essentially the preferred recommended regimens. Once again, it's all integrase inhibitor based, and the preference is, of course, for those with a high genetic barrier to resistance. The WHO guidelines, of course, in comparison are very much simplified compared to the other guidelines. This was updated in July of this year, and the recommendation there is TDF, either combined with 3TC, FTC, and Dolutegravir. So it is not difficult to understand why integrase inhibitors have been recommended as first-line ARV regimens based on a multiple number of randomized controlled trial data, comparing themselves to non-integrase inhibitor regimens, which either favored the integrase inhibitor, such as in the case of efavirenz and darunavir-ritonavir, or they were non-inferior to the comparator regimen. Rates of discontinuation, of course, are also much lower with integrase inhibitors, and integrase inhibitors, certainly the ones with a higher genetic barrier to resistance, such as Dolutegravir or BITEC, failure is not very common, but if it happens, it tends to occur without resistance. And these are just comparing the different types of integrase inhibitors used in treatment-naive patients. Bictegravir is probably the newest, integrase inhibitor. It was launched in Thailand only a couple of days ago. It has the least amount of data and is only available as a single tablet regimen of FTC, TAF, and Bictegravir combined. But it does have that high barrier to resistance, very similar to Dolutegravir. There's very little safety data in pregnancy. Dolutegravir has longer-term data. It also has that very high barrier to resistance. But there have been recent concerns regarding conception and early pregnancy safety. It has some drug-drug interactions, such as increasing metformin levels, which are generally workable. Alvitegravir is probably on its way out in the sense because of it tends to be co-formulated with a pharmacokinetic booster called colbicistat, and this tends to be associated with multiple drug interactions as a result. Dolutegravir is a good, clean drug, has been so for longest time. In certain countries like my own, it is not registered as a once-daily regimen and in itself can be a barrier to use. WHO, looking at the ARV guidelines, now recommend TDF3TC or FTC and dolutegravir for all patients, including women of childbearing potential. Efavirenz 400 milligrams has now made it into the alternative first line, and this is largely because of, over the past year, there's been increasing safety and pharmacokinetic data in both populations of TB co-infected patients and pregnant women. Efavirenz 600 milligrams has now moved into the special circumstances, and TAF has made also an appearance within the WHO guidelines under special circumstances. But is efavirenz so bad? I mean, we've been using efavirenz for really donkey's years. Why are we only starting to really hit efavirenz very hard now? So the pros and cons of efavirenz. It can be given once daily. It's very cheap. It's co-formulated. We have a huge experience base with it, and it's still the preferred drug for TB co-infection. Its side effects generally are predictable, treatable, and substitution's relatively easy. There's a low barrier to resistance at virological failure, but the concern is that there's an increasing recognition of neuropsychiatric side effects, including depression and suicidality. There is, of course, also the concern about hyperlipidemia. Most patients on efavirenz currently have to be started on a statin. Gynecomastia is reported in a lot of African populations, and you have the troublesome rash and hepatitis at the beginning. And, of course, drug-drug interactions. Efavirenz 400, now in the WHO guidelines, this is the ENCORE-1 study. This is 96-week data showing that efavirenz 400 milligrams is non-inferior to the 600 milligram. And is also associated with a reduction in treatment-related adverse events related to efavirenz and treatment discontinuations due to efavirenz. Some of the treatment-naive studies recently, over the past year or two, have been done in resource-limited settings. This is one of them. This is NAMSAL, looking at dolutegravir and efavirenz 400 milligrams in treatment-naive in patients in Cameroon, where the primary endpoint, where they were randomized either to dolutegravir or efavirenz 400 milligram, and the primary endpoint was viral load less than 50 copies at week 48. The results essentially showed that dolutegravir was non-inferior to efavirenz 400 milligram. The rates of viral suppression were lower than what we expect normally from clinical trial data. This was a population which had a higher number of patients with viral loads greater than 100,000. And when you look and stratify the viral load response by more than 500,000, you find very low rates of suppression in both groups. Dolutegravir is preferred by WHO because of the high genetic barrier to resistance, the very good efficacy. It decays your viral load, suppresses your viral load very rapidly. It's active against HIV-2 infection and has fewer drug interactions. But there are concerns with dolutegravir. This was real-world data reported back in 2018 by two German clinics from January 2007 to April 2016, reporting high rates of neuropsychiatric events leading to treatment discontinuation. The advanced study in South Africa looking and comparing dolutegravir versus efavirenz-based regimens in treatment-naive populations looked at three different regimens, TAF, FTC, dolutegravir, compared with TDF, FTC, and dolutegravir with the standard of care TDF, FTC, efavirenz. This was a population with a high rate of NNRTI resistance at baseline, 15%, 60% female, so larger than normal female population, and a predominantly black population with a mean CD4 count of 337. Viral suppression rates were much higher than that was seen in NAMSAL, but dolutegravir-based regimens, both of them were non-inferior to efavirenz-based regimens, with higher frequency of emergent resistance, both NRTI and NNRTI in the efavirenz arm, and high grade of grade 3 and 4 and adverse events in the efavirenz arm. What has been more concern, and certainly a topic of interest in a lot of conferences of late, is the concern around weight gain associated with dolutegravir, particularly when it's combined with TAF. And here we see, divided by gender, the weight gain is significantly increased with dolutegravir compared to deferrants, and certainly with TAF compared to TDF. And men experience, and this is in the advanced study, experience a plateau in weight gain at about week 48, but women continued for their weight to rise. So much so that by the end of week 96, there was a 10-kilogram increase in weight in women. Looking at specific factors which may be associated with the emergence of treatment or emergent obesity, certainly the use of TAF and dolutegravir in the regimen, low baseline CD4 count, low baseline viral load, and high baseline BMI at the beginning or initiation of antiretroviral therapy. So what it appears that this is no longer, this is a signal. It's a signal that needs to be taken very seriously because it has possible implications on metabolic disorders and diabetes. What we know right now from both the advanced study and a couple of analysis of randomized controlled trial data is that integrase inhibitors compared to other classes are associated with larger rises in weight. Within the integrase inhibitor group, dolutegravir and bictegravir are associated with the larger rises in weight. And within the NRTI group, TAF is associated with the larger rises in weight than TDF. There's been a lot of data about preconception dolutegravir and the incidence of the prevalence of neural tube defects. Fortunately, ongoing surveillance of the Botswana cohort looking at birth outcomes on dolutegravir at the time of conception revealed a reduced prevalence of NTDs to about 0.3 compared to the initial 0.9. And this was supported by no neural tube defects in the Brazilian cohort in women who were exposed to dolutegravir at the time of conception. And a lot of hypotheses was postulated whether this was lack of folate supplementation before pregnancy in women. A lot of community engagement with women was not undertaken, and very little informed choice was given. But what it does, it highlights the poor access to effective contraception for the majority of our women and poor sexual and reproductive health globally. Following this reassurance of a reduced prevalence of neural tube defects in women at the time of conception, WHO updated their recommendations to say that dolutegravir can now be prescribed for all adult women and adolescent girls of childbearing age or potential who wish to become pregnant, provided they have been fully informed of the potential increase in the risk of neural tube defects. Now, coming back to dolutegravir and transitioning to dolutegravir, this is looking at HIV pre-treatment drug resistance in Thailand. This was in 327 patients and in 20 hospitals, done in 2016 to 2017. Here, the overall pre-treatment drug resistance was 8.2%, with an NNRTI resistance of 8.1%. which is less than the 10% threshold which WHO recommends for transitioning to dolutegravir. A country such as Malaysia, unfortunately, which currently doesn't have access to low-cost generic dolutegravir, now is in the process of updating its guidelines and will need to consider whether it can transition. And it's likely that, unfortunately or fortunately, it seems likely that we will not be able to transition to dolutegravir, but we'll have to continue to transition to Favrance 400 milligrams. Finally, coming up with my last slide and some considerations in returning to same-day antiretroviral therapy. In terms of some criticisms have been directed towards the type of regimen used in same-day antiretroviral therapy. A lot of the research of same-day antiretroviral therapy in resource-limited settings have been using regimens of a low genetic barrier, because that's what we've got here, and really it should be in keeping with current guidelines. And this is discrepant with some of the guidelines which advise you to use high genetic barrier drugs, as proposed by some of the guidelines such as ISUSA. In conclusion, same-day antiretroviral therapy initiation is feasible and acceptable in HIV testing clinics and hospital settings in the Asia-Pacific. We've shown that viral suppression and retention rates are high at month 12. Even if we don't start antiretroviral therapy on the day of diagnosis, we should start as soon as possible. There's no reason to delay unnecessarily based on outdated traditions. Dolutegravir-based regimens are non-inferior to efavirenz-based regimens in resource-limited settings, and there's accumulating data to show that integrase-based regimens are associated with greater weight gain than other regimens, particularly when combined with TAF. I have a very much smaller acknowledgement list than my previous speaker, but I'd like to thank Pitch Secor, who is not here with us. I think he's led a lot of the work in same-day antiretroviral therapy in Thai Red Cross, and as I always say, lives, breathes same-day antiretroviral therapy, and mentored by Dr. Nitaya Panupak. I'd also like to thank the Thai Red Cross AIDS Research Center and HIV-NAT for their gracious hospitality and for being excellent collaborators throughout the years. Thank you.